Hello, everyone. We are joined this afternoon by Rebecca Penn and Alexandra Holtom. They are here to tell us about a medical model of safer supply and how it fits on the continuum of care for people who use drugs. Welcome, Rebecca and Alexandra.
Thank you. Thank you. So yes, I'm Rebecca Penn. I work with London Intercommunity Health Centre. I'm a project manager for the National Safer Supply Community of Practice. I'm a settler who has lived and worked in the ancestral territories of the Haudenosaunee, Ojibwe, Chippewa, and Anishinaabe, and inland that is covered by, or that's part of the Dish with One Spoon territory. Alex.
Hey, hi everyone, I'm Alex. So I work with the Canadian Association of People Who Use Drugs, also known as CAPUD, and I work as a knowledge mobilization specialist for the National Safer Supply Community of Practice. Very happy to be here. I myself am located in Tiohtià:ke, or colonially known as Montreal. The Kanakahage Nation is seen as sort of the custodians of the land, but it's also known as a gathering and meeting place for many different Indigenous groups and nations. And so I want to honor my privilege and be cognizant of my space and my place here as a very white settler here today. Really excited to be here with you. We have a very short amount of time, and so we'll walk you through our presentation and then hopefully have some time for questions at the end. So for today, our background, I'll give you a bit of background around why we're here, why we're talking about this issue, and what's happening with drug poisoning deaths in the country. And then we'll get into sort of the nuts and bolts of what is safer supply, talk a little bit about the differences between medicalized and non-medicalized models of safer supply. And then Rebecca is going to give us a nice overview of safer supply programs across the country and what's happening, and also provide us with some evidence, emerging evidence from different research studies and evaluation reports that talk about the successes, but also some of the challenges related to providing safer supply across the country. And then we'll tell you about the NASCOP. We'll tell you about the National Safer Supply Community of Practice, what we do, and what we're about to do. And so to give you an overview, a little bit of background, sort of like why we're here today, and why our community of practice exists, is sadly and tragically and infuriatingly, there's been over 25,000 deaths from drug poisoning since 2016 across the country. And we want to be really, really clear about defining the problem here. The problem is not because of the overprescription of opioids. It's because people are essentially forced or kind of have no choice but to resort to accessing the unpredictable contaminated drug supply on the streets, and also pointing at criminalization and prohibition of drug use and of people who use drugs as sort of the main causes for why people are dying, not to mention the stigmatization on societal, personal levels as well. So we've really, really heard in the last number of years, this call for sort of a need to open up our minds and our hearts and open up a door to sort of having a wide range of options, simply with the goal of saving lives. You can pop to the next slide there, Rebecca. Thanks. So really the ultimate call for safe supply itself comes from groups of people who use drugs, and they have been calling this for years. And so ultimately, when we're talking about safe and safer supply in general, we're talking about providing a pharmaceutical grade drug supply of a known quantity and quality to adults who use illicit drugs and who are at risk of overdose and other harms. And so, like I said, there's differences in the models between medical and non-medicalized models. And the one that the National Safer Supply Community of Practice is currently working to expand, given that it's the most feasible to expand in our current regulatory context, is the medical model. We are pushing to be really clear, though, that harm reduction and public health are sort of at the center and rooted in the approaches that we're taking in a medicalized model. Most of these safer supply programs are rooted really in primary care service provision, wraparound care service provision. You'll find a lot of the programs operate in community health centers, other primary centers, and addiction medicine clinics. And just a quick note on the concept of safe versus safer. And so you may have noticed that we use this term safer supply as opposed to safe supply. The reason that we're positioning ourselves is for a number of reasons, but the two most important are: the first is that medicalized approaches to safer supply are really only safer right now because the guidelines and policies that are currently in place simply do not adequately or appropriately address the needs, the express needs of people who use drugs that are accessing these programs. And so ultimately, this term of safe supply came from communities of people who use drugs that have been advocating for this for a number of years. And we really want to recognize that what the medical model is offering is simply not what people are envisioning when they kind of had this term in mind. The other idea also or positioning around it is that Health Canada and many of the programs that are providing hydromorphine prescription opioids refer to these programs as safer, simply with the idea that the use of opioids can always come with some form of risk and so cannot fully be called safe. So with that, I think I'll pass it off to Rebecca, and you can bring us into, oh no, this is mine as well. It's okay though. So there's a number of different models and there's a number of different approaches and programs, but these are kind of the guiding principles that are really helping guide the programs that are happening across Canada. And I think the main one here to really highlight is that people who use drugs and people who use safer supply programs are the expert of these programs and are the experts of safer supply. So the good old, slogan, the nothing about us without us, is really, really important to us and is really centered in our work. We also support the idea kind of in the same vein as people who use drugs are experts. Well, we really want them to be centered in the person, like have it be participant-centered care delivery and also have it be participant-led. So we really want the folks that are needing or using those services to actually be included in the delivery of them as well. And again, just really reinforcing harm reduction and a public health approach, and not just acknowledging that drug-related harms can come from drugs themselves, but also from things like criminalization. We're also really supporting low barrier care, so making it easy and accessible as possible for folks to access services, as well as really supporting practitioners and clinicians in taking a non-punitive approach. So when folks miss doses or they have missed appointments, assessments, or if their urine drug screening, for example, comes up saying that they have used other illicit drugs while on safer supply, we're really supporting practitioners to have open dialogue and to support their patients through that process, as opposed to simply discharging them from the program. I think it is now your turn. Go for it.
Alex. Yeah. So in 2019, Health Canada struck a safer supply implementation task team, and they wanted to look at what is safer supply, how do we define it, what kind of models would be appropriate and possible in the current legislation and regulatory context. What is the role of safer supply on that continuum of care for people who use drugs? So this task team did a whole bunch of consultations with lots of different people across Canada, and they saw safer supplies existing on a continuum that's anchored on one end with traditional OAT, so like methadone, Suboxone, and on the other end with non-medical models like cannabis, or like a cannabis buyers club kind of style model, compassion clubs, that sort of thing. But where they saw the most action was needed and also feasible was in this middle part of the continuum, where they had these this idea of an enhanced model, which would be an IOT program, and then flexible models that are really embedded within community settings, and taking a very, very low barrier approach, and very much focused in harm reduction. So this work paved the way for SUAP-funded projects that were intended to pilot safer supply programs with the goal of building evidence and expanding services for people who use drugs. And currently there's 17 SUAP-funded projects, but they're about to announce some more funding results. So hopefully that number will go up. But I also want to acknowledge that there's a lot of other projects or programs that are happening without dedicated funding that are part of core operations, or happening quietly on, I don't know how they're surviving. And then there's also some private practice folks and people in addictions medicine settings who are also doing this work. But a lot of these SUAP-funded projects are within community-based settings, either in harm reduction services, in community health centers, and the models that are being used both, reflect that continuum, that middle of the continuum, the enhanced models, IOT, TIOT, as well as the flexible models like a daily dispense tablet program. The majority of Safer Supply programs provide clients both traditional OAT along with Safer Supply. So they prescribe methadone or Cadian that acts as a long-acting backbone, and as well as a short-acting opioid like Dilaudid. And the majority of programs are they're provided by people who are interdisciplinary teams that include people with lived experience, and they provide wraparound supports. And most programs have advisory councils to help inform the development, delivery, and also the evaluation of programs. So as I said, these pilot projects funded by SUAP are also intended to be evaluating and building the evidence for Safer Supply, but there's a ton of research happening right now. And part of our community practice work is to track what studies are happening and follow the literature. And so without going into lots of detail, but I'm happy to, if anybody has any questions or want to reach out to me afterwards, these are some of the different studies that are happening. There's at least 27, and very mixed methods, lots of different approaches. Health administrative data is being used, qualitative research, quantitative research, all kinds of great stuff happening. I'd like to share with you briefly some of the preliminary findings from program evaluation. There's all SUAP-funded projects do have an evaluation component to it. I'm based at London Intercommunity Health Centre, which first started doing a daily dispense tablet program in 2016, first of its kind. And I'd like to share some of the recent program evaluation findings that we've just released. So key here is that this program has been going on since 2016, like I say. And what we did with the evaluation is we looked at experiences and characteristics of new clients just joining the program compared to clients who've been on the program for a while. And we saw a lot of amazing benefits happening for people, improvements in health and social well-being. For example, 59.6% of people who've been on the program for a while reported that their health had improved while being on the program. We also saw reductions in overdose and overdose risk, increased access to health and social services, reductions in emergency department visits and hospitalizations, improved relationships with family and friends was a big one. Reductions in the use of fentanyl and other street-acquired drugs, increased feelings of safety, reduced engagement in criminal activity and reduced contact with police, and reduced injection drug use. About 35% reported that they had stopped injecting drugs altogether, even though that's not a goal of the program. The goals for Safer Supply programs are completely determined by each individual client. And for some, it is reducing the use of street drugs, changing the way that they use drugs, that sort of thing. And for others, it's really just about reducing their exposure to the illegal drug supply. I also want to point out that many of the clients emphasize the importance of experiencing positive relationships with healthcare providers and social service providers, and just how I think this points to the potential role of Safer Supply in transforming relationships and transforming the experiences that people have with healthcare professionals and in healthcare settings and social service settings. I want to share with you some quotes that we pulled. Choosing which quotes to share was almost impossible, but here's a couple of good ones here. If it wasn't for this program, I really don't think I'd be here right now and feel as healthy as I do. I got my Hep C taken care of. I can walk with my head held high. We don't have to go to the streets anymore to make our habit, to make money to pay for our pills. Since the program, I haven't gone to jail and I'm pretty much not working in sex work. It's saved my life. For myself, it's helped my relationship with my family now. I can go take my daughter's kids out, which she wouldn't let me do before. I've been on the program almost 4 years. For me, it's the relationships I've gotten with people that I haven't had before. This is a word cloud I'd like you to take a look at for a moment. I'll be quiet, let you have a look. It was created based on findings from qualitative research or qualitative interviews that were conducted for evaluation of the 10-month funded SUAP programs in 2020. So along with these benefits, the evaluations are finding that there's also a lot of challenges facing safer supply programs. First and foremost, it's the demand for safer supply programs. The supply of programs, of prescribers, of services are not meeting the demand at all. We need more safer supply programs. We need more safer supply programs that have different entry points and types. So for example, we need both observed and unobserved models. So IOT is an observed model, and some of the daily dispense tablet models also have an observed arm. So the daily dispense tablet models typically are not observed dosing. A client would come to the pharmacy, have an observed dose of their slow release oral morphine, like their Acadian, or their methadone, but then they get their safe supply prescription, their safe supply dose to carry with them for the day. But that doesn't work for everyone, and it's not. And there are people who aren't eligible for that take-home dose, particularly people who use a lot of alcohol or benzos. They may not be eligible. So having that observed option is really, really important. We're also finding that the programs that do exist have insufficient program capacity, and that puts a lot of tension on community members as well as staff needing to triage who gets access and things like that. We also need a wider range of medication options. We need different types of medications. We need smokable formulations, injectable formulations. We need these to be covered by drug benefit formularies. We need different strengths to meet different needs and wants. We also need to address the ongoing stigma and lack of understanding about withdrawal, about pain management, about safer supply that people encounter in health and addiction services settings, as well as in correction settings, so that we can have continuity of care. And we need to make sure that we're very clear about what the goals are of safer supply, what the principles are, and how that is distinct from a lot of addictions treatment models and options, even though it's on the same continuum. And of course, we need to address the social determinants of health as one of the major factors here. So in addition to some of these program evaluations, we're starting to see some peer-reviewed evidence coming out, being published, that is also suggesting and repeating or reflecting some of these benefits we're seeing in the program level. I really just want to highlight here that the evidence is pointing both to positive outcomes at the individual level, but also the community level, including looking at the way that safer supply can address structural barriers and address equity issues. Emerging evidence is also addressing some of the major concerns that people have about safer supply. One particular concern that people often raise is this issue of diversion. Although diversion is an issue for the prescribing of all kinds of medications, including opioids, including opioid agonist treatment like methadone, it's been a really big big concern brought up about in the context of safer supply, especially around the models of the daily dispense take-home programs. But what the data suggests is that prescribed opioids are not adding to the deaths related to opioid toxicity. We're getting coroner data from BC and Ontario right now that really emphasize that the majority of the deaths of the opioids involved in people's deaths is fentanyl. And we're starting to see more literature that is looking at the possible protective factors arising from diversion, particularly like in terms of diversion of dilaudid. And this is causing us to rethink what diversion is all about, including seeing diversion as an act of caring between loved ones. So if someone that you care about is experiencing withdrawal and you have medication that would help that, that's an example of a practice of care. Also looking at how a lot of safer supply programs are looking at how diversion is an indicator of an unmet need. Either a family member who actually needs access to a safer supply program and safer supply prescriptions, or perhaps it's another basic need like a need for housing or food or income. I just want to quickly show you this slide. It is from it's from the coroner's data that just really highlights the opioids, that hydromorphone deaths related to that had hydromorphone related are actually lower during the pandemic than pre-pandemic, even though that's when we saw the most increase in the prescribing of safer supply. Also injecting tablets, there's evidence that says that, yes, there's concerns around, injecting tablets is not ideal. However, the data does not support the assertion that safer supply of hydromorphone is driving infection rates. And then I'm skipping through this just because of time, but happy to answer some questions after. In terms of moving forward with safer supply, we know that that the current models are not perfect, that there's still a long way to go. A big issue that we need to do is figure out how to support prescribers so that they can feel that they can offer safer supply as one of their tools in their toolbox for providing care for people who use drugs. We really need to work on developing models for rural and remote areas and different specific populations. We need that advocacy around pharmaceutical alternatives that I talked about, like the injectable options and things like that. We need to make sure that safer supply maintains this harm reduction and public health focus, and addressing the stigma and discrimination in acute care settings and corrections so we can have continuity of care. And ultimately, we need to move beyond this medical model as called for by people who use drugs and also many members of the medical community, looking at non-medical models, how to make that happen, and always linking and going back to the social determinants of health. Alex, turn it over to you.
Yeah, so we are from the National Safer Supply Community of Practice. So you may or may not know we receive funding from Health Canada's Substance Use and Addictions Program, so SUOP. It is a collaboration between 3 different organizations. So the organization that Rebecca is from is London Intercommunity Health Centre, myself from the Community Association of People Who Use Drugs, and then lastly, the Alliance for Healthier Communities. So it really is our goal as a national safer supply community of practice to support healthcare and social care providers who are providing care for people who use drugs who are at risk of harms from having to rely on the illicit drug supply. So it's really our goal to expand and support the expansion and the development of safer supply programs across the country. And we do that by facilitating knowledge exchange, skill sharing, and capacity building. and really also focusing on trying to build community connection and engagement and open dialogue. We're also really trying to avoid or reduce, I guess, the duplication or the sort of doubling up of work, and making sure that we're collaborating instead of sort of repeating the same messages from different streams. As we've said before, we do work within the medical model of safer supply that is both harm reduction and public health approach based, but we do strongly support and advocate also for the non-medical models and compassion club style safe supply programs, but also decriminalization. So far, I'm really happy to report we actually just launched our membership at late September, very early October. We already have over 645 members. And so I think that really just speaks to like the hunger and the sort of the desire for this information and to connect and to communicate about this topic. Our membership is extremely diverse. It's from across the country, urban, rural, and remote regions. And we're really hoping to bring more rural and remote regions into our community, community of practice, which is also why we're so happy to be here. We also have English and French speaking members. I'm really well located here in Jaujaguet to be able to connect with the Francophone community as well as other French speaking populations across the country. And it's extremely interdisciplinary, our membership. And so we have nurse practitioners, doctors, nurses, social workers, people who use drugs, researchers, activists, all sorts of stuff. And lots of those folks sort of fill a number of those roles as well. And so we're really proud to have that membership be really highlighted. We will share at the end. I found out that we can't chat to you during the presentation. And so we'll share with you a number of links so that you can sign up to see really what all of our work is about. We do one of the main things, if you want to go to the next slide there, Rebecca, is our prescriber consultation line. So nurse practitioners and clinicians and doctors that are wanting to prescribe safer supply but needing support are able to access that line. We'll also include in our follow-up a number of links and resources on our website about the work that we do. And Rebecca, maybe you want to tell them a little bit about what's coming up, and then we can answer some questions.
Sure, that sounds great. So we do a lot of professional development and skill sharing stuff as well. So we just had a wound care for clinicians. We're organizing a wound care for non-clinicians right now, including people who use drugs. We have a bunch of public webinars. We have a weekly drop-in meeting where all of our members are welcome to come and just bring up different things that's happening for them. But then we also have a monthly hot topic event that's public. And this month we've got perspectives on decriminalization. We're snuck in a second one in March where we have Dolph coming to talk about non-medicalized models. That's important for us to emphasize that piece as well. And then at the end of the month, the Safer Opioid Supply Guidance document that was developed by the group in Ontario about the daily take-home tablet model, that guidance document has been updated. And so they're going to be launching that and discussing that. We also have a bunch of other things underway, including some regional conferences, regional meetings, and then some other hot topic-y types of events, including on these different topics around ethics of safer supply, Indigenous harm reduction, and safer supply in rural and remote areas, neurodivergent, substance use harm reduction, and safer supply. We also have a bunch of working groups that are happening, including a pharmacists working group, program operators working group. So for those groups, we're looking at policies and tools, and then also some topic-based working groups, like a working group on reframing diversion, on accessing alternative pharmaceutical options, things like that. So you can find a lot of our information on our website. We're just about to, like literally today, we will be launching an upgraded version of our website that's going to have a massive resource library in there, searchable library. And eventually we'll also include members only space for discussion and things like that. Some questions.
Yeah.
Jeff, do we just look at the questions in the chat here?
We can read them off. Yeah. Great, thank you. So there's one of the first questions was, what would you say to people who say that safe supply encourages or enables drug use? I would sort of say that this is a trope that was used also to kind of attack approaches of harm reduction, right? So that by providing people with safer supplies of drugs, of harm reduction supplies, et cetera, they're going to be encouraged to use. And actually what we really know and what research and history has shown us over and over again is that drug use is very human, and people will use drugs regardless of what they have or don't have like access to. And so ultimately, with the goal being with safer supply, that we are able to provide people with a kind of a known quantity and quality of the drugs that they're using to be able to use that as safely as possible. And really, I would say that safe supply doesn't encourage or enable drug use. It actually encourages, enables life and the saving of lives. There's another one, maybe Rebecca, I'll read it to you and you can answer. Can you say a bit about the goals of safe supply that you, sorry, let me try again. Can you say a bit about the goals of safe supply that you mentioned are? How is it different from something like methadone or other opioid agonist treatments?
So first of all, I'll talk about the goals of safer supply, the medical model that we have. So the goal is basically to keep people alive. It's to reduce their dependence on the illegal drug supply. So where addictions medicine has often focused on reducing someone's drug use and working towards abstinence, safer supply, clients to safer supply might come in with those goals, but the goal of safer supply is literally to take someone and reduce their dependence on the illegal drug supply by giving them a drug of known quality, potency, and also will still have the same effect, more or less, that the client is looking for. So it is about providing the medication, and then also along with that, having the open door for people to then, as they wish, participate in primary health care, access wraparound services, and things like that. Anything else to add to that, Alex?
I think that's a really good explanation. There's also another question. So there's a question about diversion, which I'm happy to take after. There's another great question here that you might be able to speak to. Can you talk a bit more about how this model would need to be adapted regarding rural and remote areas?
Yeah. Great question. So a big piece is within addictions medicine and falling into safer supply is a lot of policies and regulations around monitoring people, daily monitoring, observed dosing. So people having to go and pick up their methadone every day. And indeed, that's the case with safer supply, especially with the long-acting medications. Those need to be observed because of the increased risks associated with injection of long-acting opioids. And so it is this, it's very high, even though we try to make it as low barrier as possible, because of the current kind of guidelines around this kind of care for people, it often focuses on this monitoring, observing. So for somebody, I think it's similar with the challenges that rural and remote communities face with OAT, that having to go in daily to pick up their medications. If there's not a pharmacy in your neighborhood, if there's not those services like right there, then figuring out how to do the distribution is really, really difficult. The other thing is that the observed programs are really expensive, they're quite expensive compared to an unobserved model, right? You need staffing, you need space, you need a way of storing and storing and providing the medications. So that can also be a real barrier for those observed models. So I would love to see some work happening around models and different ways of approaching.
Yeah, so we have time for one more question. The question was simply, what is diversion? And so when we're talking about diversion, I really want to frame this as it basically means to divert your drugs or reroute them or displace them to another person or for another purpose. And I want to be really clear that diversion does happen, as Rebecca said much earlier on when we were talking about evidence. The diversion happens actually with a number of different medications, right? It happens with college students providing Adderall to their friend to help them finish their assignment that night. It happens with folks passing off antidepressants to other people, other types of painkillers, all sorts of drugs. And so this isn't a phenomenon that we see happening just exclusively with safer supply. We also know that it's happening. A lot of the research, for example, comes from things like methadone, research studies on methadone or even Suboxone. And so diversion really just refers to sort of the displacement or derouting or rerouting of a prescribed medication to another person. And I also want to flag that there's a number of reasons why people might do this, right? So they might do it to help their friend get out of a withdrawal and pain. They might do it because they need to maybe generate some income on the street because they don't have a place to stay that night. It might also be the case that unfortunately their bag was stolen and their doses happened to be in their bag when they were going to the bathroom. So it happens for a variety of reasons. And as the research is really starting to show us, it's actually a practice of caring among community of people who use drugs.
Yeah, I just would add that when we look at diversion as an indicator of an unmet need, then that provides a way of engaging with people and finding solutions that meets everyone's needs, from the prescriber and the health system to the client as well. So yeah, I guess that's all for us for now, but you can please feel free to reach out to us. Both Alex and I do have our email addresses, or you can contact us through our website, which you can see on the screen, or through these different social medias as well, Facebook, Instagram, Twitter. Yeah.
And we'll be sure to circulate via Candace and the whole team, kind of a list of links and resources that we are eager to share with you. And we'd love to see you join the community of practice. We'll also share a link for registration.
Thank you both for joining us today. And as mentioned, we will get any of those links out to you and available on the event platform, as soon as possible. There is currently one more session just wrapping up right now, and then we can all meet in the main room for some closing remarks. Thank you.